Good afternoon. I'm Janika Pierce-Tucker, a member of CMC Board of Trustees, and I'd like to welcome you all today to the forum. It is great to see all of you. Today's forum, in order to form a more healthy nation, is part of the Our Healthy Community series presented by CMC and Ohio Health. Please help us thank Ohio Health and their representatives here today for their ongoing support. Today, despite passage of the Affordable Care Act facilitating access to health insurance for everyone, the already high cost of coverage, treatment, drugs, and deductibles continue to rise. So some wonder, what is the affordable part? Is the affordable part of the act is kind of questionable. A health crisis for an individual or family continues to be the #1 cause of financial ruin in America, representing 62% of all bankruptcies, despite the fact that 78% of those filers had some form of health insurance. Meanwhile, obesity, diabetes, smoking, diet, lack of exercise, and other personal lifestyle choices make us prone to problems. Clearly, there is work to be done. We turn to our panelists today who battle these complicated issues on a daily basis. Please welcome VP of Community Relations at Cardinal Health, Diane Radigan. Health Commissioner, Columbus Public Health, Dr. Teresa Long. Director of the Governor's Office of Health Transformation, Greg Moody. And President of the Health Policy Institute of Ohio, Amy Rohling McGee. Amy, the podium is yours. Thanks.
Thank you, Janika, and thank you to the Columbus Metropolitan Club for inviting us to be a part of the conversation today. Let's start with this thought. The health of our population affects economic development, and the strength of our economy impacts our health. While most of us here today are likely in good to excellent health, with access to care, good food, opportunities to exercise, jobs that pay more than the average state income, and maybe a college degree or two under our belts, this is not the case for many in our nation, our state, or our community. 2013 per capita healthcare spending in the US was more than 2 times that of other economically developed nations. Compared to those nations, the US also had poorer health outcomes. A little over a year ago, the Health Policy Institute of Ohio, the organization that I represent today, released a health value dashboard, finding that Ohio ranks 47th out of 50 states in the District of Columbia on health value, which is a measure that combines both health outcomes and healthcare spending. And according to the county health rankings, Franklin County ranks 52nd out of 88 counties, squarely in the bottom half of all counties in the state. We've put copies of those documents on your table. The CMC deliberately only puts a few copies on the table so that you can all kind of share those. So you have both the health value dashboard summary and county health rankings, the page for Franklin County, if you want to look more closely at some of those metrics. Our specific statewide health challenges include smoking and exposure to secondhand smoke, infant mortality, access to drug treatment, and food insecurity. At the local level, we struggle with adult smoking and obesity, high school graduation, housing issues, infant and child mortality, food insecurity, and drug poisoning deaths. I'd like to note that there is a lag in national, state, and local data. So tools like the Health Value Dashboard and the county health rankings will not yet reflect data related to the impact of policy changes that have happened in more recent years. For instance, the Affordable Care Act and many other state-level policy changes. However, these challenges are significant, and it's likely that there's still as much work to be done to improve. Today, we'll have the opportunity with the panelists to discuss efforts being made at the state and local level and in the public and private sector aimed at health improvement. Researchers have estimated that our overall health is impacted by a number of modifiable factors, with just 20% attributed to health care. So I want that to sink in a minute. And there's a graphic at your table, a pie chart that illustrates this. So researchers have looked at all of the available data, and they've estimated that just 20% of our modifiable health is attributed to access to care, meaning clinical care and quality of care. If you think about even in your day-to-day life, most of us are not going to the physician or going to the hospital on a daily, weekly, or monthly basis. Hopefully that's not the case for most of us. But think of everything else that influences your health. As I mentioned earlier, it's the food that we eat, the opportunities that we have to exercise, where we live, whether we have clean drinking water, whether the air we breathe is healthy. All of these are much higher contributors to our overall health. 40% is attributed to our social and economic environment, which includes income, educational attainment, 10% to our physical environment, and 30% to our behaviors, the choices that we're making every day. We often like to say that access to care is necessary, but not sufficient to achieving positive health outcomes. Of course, if you're sick, if you're injured, if you have a chronic health condition, access to care matters a lot, and access to high quality care matters a lot. But unless we address these other contributors, we will not, let me repeat that, we will not see improvement in overall population health outcomes. So I'd like to start off today just asking our panelists to share a little bit about each of their companies or the sectors that they represent so that everyone in the room has an understanding of where we're all coming from. I'll start out with our organization, the Health Policy Institute of Ohio. We're a small nonprofit organization that was created by a group of foundations and United Ways from throughout the state several years ago in 2003. These foundations and United Ways felt that there was a need for an organization that was independent, unbiased, and nonpartisan to analyze and provide information and analysis to policymakers and those who influence policymakers so that we have sound health policy in our state. We are, as I said, a small staff. HPIO staff, can you raise your hand? So pretty much our whole staff is here today at one table, including a couple of our board directors as well. So now I'd like to start with Diane. If you could share a little bit about Cardinal Health and the role you play in that organization.
Yeah, sure. Thanks very much. Appreciate that, Amy. I've had folks say to me in the past, who is Cardinal Health? Are you a fitness center? And so it seemed like a good idea to say a little bit about who we are. A large Fortune 20-ish company, multinational company, about 35,000 employees, but the whole purpose and focus of our business is to help those who are in healthcare, clinicians, do the very best job and get the very best patient outcomes at the lowest cost. Many folks will think of us as a distribution company, distributing pharmaceuticals, which we certainly do. We have many different, pretty interesting business and patient solutions as well that have grown and evolved as the world of healthcare has evolved. My role is community relations for the company. It's just a great gig. Really blessed.
All right, Greg, tell us about the Governor's Office of Health Transformation.
My name's Greg Moody. The Governor's Office of Health Transformation is a new creation. The governor had this insight as he was thinking about running to be governor, that a lot of the challenges in state government result from these challenges any complex organization has, which is when you divide your resources up and you categorize them and you separate them, a lot goes wrong. That a lot more good can happen when you coordinate, when you collaborate, when you identify how to pool resources to bring them to bear against a particular problem. So in state government, we had a Department of Aging and Health and Mental Health and Alcohol and Drug Addiction. We brought all of those under the umbrella of the Governor's Office of Health Transformation to coordinate strategic planning and budgeting across those organizations. So it was a new idea. I've got to say, I think it was a great idea. It's the most fun I've ever had in public policy. I see a number of folks here who I've worked with over about 30 years in public policy, and teams really do work. So it's been a pleasure serving in that capacity.
Well, good afternoon, and my name's Teresa Long, and I'm your health commissioner. So I'm glad you're here. Hopefully you all have had a good and safe and healthy meal. Let's hope. So what is it that we do at Columbus Public Health? Well, we are completely focused on protecting health and improving lives. We do that in many different ways. 8,000 licensees, just talking about restaurants and many others that we license, but we also have strong commitments in the areas of neighborhood health and working directly with neighborhood organizations, but residents, as far as creating the conditions in which people can be healthy, which really is what public health is all about. We also have a very strong family health section. We'll talk a little bit perhaps about infant mortality, again, environmental health, and then clinical health services. So again, we are very committed, slightly larger than Amy's team. No, actually, we're a pretty big team. But again, we are all about working with you, your organizations, you as individuals, to again create the conditions in which you and all of your employees, your loved ones, can be healthy.
Great, thank you. So I shared a lot of data, and the data is kind of a downer. But I'm wondering if each of you could reflect on one or two drivers of those outcomes that we're seeing at the state and local level. So what do you think is contributing? Of course, let's just start by saying that it's very complex. There's likely multiple contributors, and that's part of what we lay out in the health value dashboard, is that it is a very complex picture. But if you could just share from your perspective, what are one or two of the primary drivers of poor health outcomes? And maybe we'll go backwards this time. Maybe we start with Dr. Long and then work our way backwards.
So I'm the backwards one. I'm kidding. So there are so many different drivers of these challenges that we all face. So again, I appreciate that it's complex. One of them is us. I mean, we are part of it. It is both how we live, as Amy pointed out, about our own personal behaviors. It also is very connected to our social and economic opportunities or lack of opportunities. I think it was just mentioned that health is more than health care, and I would be happy to explore that with you. I hope we get to that, because indeed, as was pointed out, medical care itself, while very important, and we are very excited and supportive of our health systems and our providers, if we do not address the other determinants of health, the social determinants of health, we will never be as healthy as we want to be. And so again, I think that's really what population health is all about.
Well, this idea that it's so complex, where do you start? 4 years ago when we were trying to put together a state policy, that was really true. And the governor is a very pragmatic and practical person and thinks of the state as a CEO would think of a company. And this idea about what do we spend money on was the starting point for sorting out where we could really have an impact. A third of the state's budget is spent on health care. The state of Ohio determines a significant portion of health policy for the healthcare marketplace in Ohio. So if we weren't getting the results we wanted, what was behind that? And I think there's pretty much general agreement now that however it's happened, we sort of get what we pay for in healthcare. We've sort of complacently ended up in this situation where what we do is pay a fee for every service, which creates an economic incentive just to provide more service, whether or not it's keeping a person healthy or not. That kind of volume-driven activity generates some bizarre results. You get more of what you don't need, and you get less of what you need to keep people healthy and out of the system. Now, there are a lot of organizations that are in that setting that are really swimming upstream. They're trying to get out of this volume-based business and do what's right. They're trying to prevent illness to avoid other higher costs. But we don't pay them to do that. And if they accomplish that, all that happens is they get paid less. When you keep a person healthy, it just means they're not in your emergency department. You get paid less. So the financial incentive is completely upside down. So a lot of what we've been trying to focus on is how do you move away from volume-driven payment to value. So now clinical medicine has an incentive to participate in what holds down the total cost of care. That's getting people connected not to clinical medicine, but to supports in the community to get them into safe housing, access to good nutrition, things that avoid disease later on. So for us, everything comes back to you get what you pay for, and we have to pretty radically change how we pay to start creating the incentives to drive toward what we want, which is population health.
Yeah, for folks to be healthy. Yeah, I couldn't agree more with both, with what Teresa said as well as Greg, and would add the importance of patient engagement to that mix, and how we take care of ourselves, how we live makes such a difference. And I've heard folks say that patient engagement is the next perhaps miracle drug that's out there if we can really get people understanding what they need to do, what we need to do to take best care of ourselves, but also to realize that sometimes our environment doesn't support that. And so there are places within our city where it's not safe for children to play outside, or there are places in our city where it's more difficult to be physically active or even to find healthy food. All that said, we've got many good things going on in our community with YMCA and providing opportunities for physical activity, and our food bank doing a great job with healthy fruits and vegetables and things like that. But we have to recognize too that for some folks it's a little bit harder than for others.
Can I jump in there? Because I completely agree. And again, we wouldn't have much to talk about if we didn't have some disparities, which is what Diane is pointing out. And it's very hard. I hear people say all the time, well, they can choose to be healthy. I would ask you to think that there are many in our community and all across our country who don't have the opportunity to choose to be healthy. If you don't have choices, you can't choose to be healthy. Good, I see people nodding. So again, it's something we need to be mindful of. You know, again, health is more than healthcare, but clearly these disparities, and they happen economically, they happen geographically, they can happen racially, et cetera. So these are all things that are definitely, I think, on our minds.
And I think the whole idea also of value-based medicine is an important one too. We have really amazing healthcare institutions in our community. I mean, it's just top-notch care. And if you need anything that's very, very sophisticated, we've probably got it here. But I think sometimes to step back and take a look, just because something can be done doesn't necessarily mean it should be done. And we start looking at our aging population and what's right for our families and others. You know, you don't have to talk much about care for elderly family members and you know, how challenging that can be. I think you'd bring that up at any time, and everybody's got a story, right, about your family and someone you're helping to care for. And I think our aging population is going to make a difference in all of this as well. And, you know, we need to get our arms around that as well.
Okay. Greg, could you share a couple of examples of policy changes or activities that are underway at the state level to address some of these health challenges?
Yeah, sure. You know, in terms of what we pay for, through Medicaid, we have more than 90,000 healthcare providers who receive payments through Medicaid. We have 3 million Ohioans enrolled in the Medicaid program. And two of the most recent kind of strategies we've been working on are to shift away from the old fee-for-service system into two very specific kinds of paying for value. One is we have under-resourced primary care for too long. And primary care is really at a crisis point where, I don't know if you know any primary care docs, but they are not content or happy. They're on this treadmill where whoever comes in, they have their 5 minutes and they have to move on. It's very difficult. There's no risk stratification to say, here's a group who maybe doesn't have to come in, but here's a person who really needs to come in more frequently and I need to spend more time with them. That kind of activity we don't pay for. So we're working on a primary care model where if a practice can meet quality measures and hold down the total cost of care, then practices that do that today get no reward. The value of that accrues to the insurance plan because they're paying less for that person who's being kept healthy. We have an agreement with the 5 Medicaid managed care plans and Ohio's 4 largest commercial insurers, Anthem, Aetna, United, Medical Mutual, to change how they pay. So if there are primary care practices holding down the total cost of care and meeting quality, they will share back some of the gain with those practices so they can further reinvest in that kind of activity. That is a sea change where now you're kind of turning the market around to create an incentive for that practice to seek partners to address behavioral health issues or housing issues or other things that drive up cost, because if those costs are held low, there's now a financial incentive. We're doing a similar thing on episodes where high-cost episodes of care occur. How do we reward specialists who organize teams to provide quality at low cost? Folks are doing that today already. They're just not getting paid for it. So why wouldn't we share back some of that gain from the insurance plan side to reward the folks who are generating value? So enhanced primary care, episode-based payments, those are 2 recent examples.
Okay, great. And then at the local level, Dr. Long, how does Columbus Public Health partner with others in the community who are also charged with improving health? I mean, maybe you could pick an example like infant mortality or smoking or maybe food access and food insecurity. There's a number of challenges. So how does your organization work with others?
So thanks, Amy. She's teeing it all up. So again, let me just comment. And again, Greg and I and Amy have been working together on many projects over many years, but most recently on a population health project. So taking the work that Greg just described to you around patient-centered medical homes and patient care to a population health project. A really important work that's just starting to be highlighted right now. So again, let me just define how HPIO defined population health, which really is the distribution of health outcomes across a geographically defined group, which results in the interaction between our biology, individual biology and behaviors, the social, familial, cultural, economic, and physical environments that support or hinder well-being and the effectiveness of public health and the healthcare system. So that's big. It's big. But it is what we've just been talking about. It is what you know. I mean, again, it's the health of our state of Ohio. It's the health of our Columbus and Franklin County. It may be the health of your neighborhood. And so thinking about that then will be a springboard. So what are some of the challenges and the strategies that have to come together? So one is we have to think beyond medical care. And again, I've got my board president here. I've got a variety of my health system partners. But if we don't think beyond the health system and healthcare, we will, again, not be successful. We also, again, have to, and again, we already talked about the patient. It is also about the patient, but it really is much beyond that. We also have to think about how do we measure what it is that we're looking at? And then how do we, again, reduce the disparities and hopefully work together, share accountability on this? So again, we could talk about everything, but let me just bring infant mortality.
Because can you describe, what do you mean by disparities? Like, what's an example of a disparity?
So that's terrific. Thank you. So there are lots of different disparities, health disparities. There are much higher rates. Well, infant mortality. So infant mortality is 2.5 times higher in our African American community than in our white community. I can tell you there are neighborhoods in Columbus that have 4 to 5 times the infant mortality of the neighborhood next door. I can tell you that life expectancy, so from something as small as an infant to as long as how long we live. We have a 20-year gap in life expectancy between zip codes here in Franklin County. We even have about 16 years between two that are neighboring zip codes. So again, this is just a measure of some of the challenges, the disparities. We can talk about all kinds of chronic diseases. We could talk about, well, we could go on and on. I would love to. But so let me talk about what we're doing. And we have worked together. And again, this is really what the Population Health Planning Project has been about, is how can we align both at the state level, both health systems and public health and partners. And we welcome corporate partners. We can talk about that too. But we've also been working very hard in our local community. So infant mortality, I know, has gotten some attention, but it's a great example where we have had lots of effort going on in this community for many, many, many years. But if we could have solved it, all of us white coats would have done that. It really was stepping back and being very broad in our learning together and in setting up both a leadership structure, an accountability structure, a measurement structure, and inviting the unusual to come in and learn together and be a part of the solution. So indeed, we spent some good time doing that, and actually we've got some colleagues who were right there from the very get-go here today. But it wouldn't have been, we would not have had the success of the Greater Columbus Infant Mortality Task Force if we had not done that work together. And now we have Celebrate One, which is again very committed to lowering the infant mortality in our community by 40% by 2020, which is a huge goal, and then reducing that disparity, the racial disparity, in half. And I'll just leave you with one other thought, is that New York City has half the infant mortality rate of Columbus. So if you don't think we can do it, I assure you we can, but we must work together.
Okay, great. And I just wanted to add, too, that a lot of times when people see the statewide data or the county level data, they immediately think that the reason why we have poor health outcomes is because we have maybe an older population or a poorer population in our state. So when we created the Health Value Dashboard, we partnered with the University of Cincinnati's Economics Center to collect all of the data, and we asked them to do a correlation analysis of those two factors. And we found that there is a slight correlation on age and on poverty, right? Poverty, yes. But it's not, there are states that have older populations that have better health value, and there are states that have poorer populations and have better health value. So it is possible, and I think what just jogged my memory about that was what Dr. Long just shared about New York City, that it is possible, given equally, if not more challenging circumstances, to have better health outcomes and better health value.
We're going to let Diane speak as well, I'm sure. But again, the infant mortality plan would be an overlay for lots of different issues. We could talk about chronic disease, prevention and intervention, but again, there is a very clear neighborhood and community-based strategy. There are clinical strategies. Honestly, we do have terrific health services and healthcare, but we can do better. And then there are some other factors that would impact chronic disease, whether it would be smoking and tobacco or how we sleep our infants. So again, it has to be a broad brushed approach to have this kind of desired impact.
Well, and if we go back to what I started with today, that the health of our population affects economic development and the strength of our economy affects health, that brings me back to Diane, because Cardinal Health is a large employer, and they're a large employer nationwide, not just here in the central Ohio area. But we wanted to have the perspective of a large employer on the panel today to talk about why community health is important to an employer, and then how the Cardinal Health Foundation has engaged or invested in community health improvement activities here locally and perhaps elsewhere too.
Sure. You know why this is important to Cardinal Health? This is our home, is what I would say, and we take that just very, very seriously, and we look at it in a very broad way. So we have our employees and our resources involved here in a way that happens in no other city. I will tell you that, although we do have a lot going on in other communities where we have employees across the globe. You see us looking at this in a broad way. Our foundation funds 3 very key initiatives that align with patient outcomes and value in healthcare is really the crux of it. So we've had work that we've done with the Children's Hospital since 2008, actually, that have led to reduced errors happening in hospitals. Things do happen, very significantly reduced errors and then spread. And that work is quantified to have saved about $90 million in healthcare costs over the course of the last few years, as well as affecting 4,700 children who didn't have something happen to them in the hospital. So that's been great work. We have a really nice initiative around prescription drug abuse in partnership with the Ohio State University College of Pharmacy and many others across the country. Actually, at this point, that has started small in Ohio and then spread. It's a terrible issue that's growing and growing, and so we have wonderful resources targeted to teens and parents and the elderly and their caregivers, as well as employers. And if you're interested in getting involved with that, we would love to have your companies involved with that work and sharing that information with your employees. And then we most recently started an initiative called Good for Growth in partnership with the Academy of Pediatrics, which is just delightful. The link to what's important to Cardinal Health, which is the overarching health and quality health care, is that we're going upstream in this case and working with children and their families around nutrition, physical activity, and the role of relationships in a caring adult in a child's life that can influence not only health, which we know it will influence health, but early brain development. And I will tell you, as someone who's worked in the field of nutrition and fitness and all that all my life, it's like pushing a rope uphill to try to get people to care about that sometimes. But when you talk about brain development in children, we have people's attention. That work is focused on pediatricians, 3 audiences: pediatricians, childcare providers, and then the general public. And it's really gotten off to a nice start. Goodforgrowth.com is where you might go to see some of those materials, and we encourage you to look at that. And then because this is Central Ohio and it's our home, we look at this very, very broadly. And so you see resources and our folks involved with housing, for example. We know there's a link between housing and health, and so involved with Commissioner Brown's Commission on Homelessness, involved in the affordable housing work that's going on in our community. You saw our CEO lead the Education Commission recently, and then put loaned execs out into the community to work with that, to work also at Columbus State for a bit. And so the point being, we know that there's a link for our company between broadly, not just narrow look at health, but what's happening in the environment. And so whether it's education or housing or poverty, we want to play our part there and be helpful and involved. It can involve financial resources, but it really involves our people, and our people are brilliant. I mean, they just are brilliant, and they come in with their hearts and they make a huge difference. I look around the room and I see places where we have board members, and I hear the stories of things that our folks do and who they bring to the table, and it's good.
Wow, I didn't know about half of that. That's really amazing. And I know Greg has something he wants to say in response, but I'm just going to mention that in a second we're going to move to audience Q&A. So if you could begin to queue up at the microphone, we'll turn to those questions in a second. Greg?
I just think it's important to reflect on kind of the cardinal view we just heard, which I think is really important. Through the state, we get to work with a lot of folks who want to do the right thing. And often there's kind of this life cycle of how you think of it. You know, you need to be compliant. You know, as a health district, you have to be accredited, so you have to do certain things. Or as a hospital, you have to do certain things that show community benefit to maintain your tax-preferred status. It's kind of that minimum level of you do it because somebody says you have to do it. And then I think where most folks are is the next level, which is charitable. You want to do good things. We have some money. We have a foundation, so we're going to support this project. The problem there is if you're supporting this project on infant mortality, and over here somebody's supporting a project on opiate abuse, well, the folks in the room here are figuring out what's really wrong is the lack of affordable housing. And over here in the infant mortality group, they came up with the same conclusion. but you've now put a little bit of money over here for this, and we kind of get in this disease of the month kind of thing where it's almost political. You know, who can get these little bits of money? The next, I think, level is strategic. Can you do things with your money that actually match your mission in a way that create a real purpose? And I think Cardinal's a perfect example, because the examples you gave are about keeping people healthy in a way that Cardinal as an organization is committed to, but it also has a direct impact on the community. And then I think there's even another level that is maybe systemic, where we're all doing that together. So I'd really challenge folks not to think that if you did your charitable thing, you're done. You might even making things more difficult. Because if it's just left at that, it divides our resources up in a community in a way that we're really not having the impact we could. That's why these community-level activities where people are coming together to address multiple problems through housing or through nutrition or whatever those things are can really have a much broader impact.
Okay, great. It's the CMC's tradition to take audience questions. Please state your name, ask your questions, and we thank you in advance for not making long editorial comments. Let's proceed with the first question.
Thank you, Amy Claben. So thank you to each of the panelists for raising the issue of affordable housing. Here in Central Ohio, there are 54,000 people that we know of that are living in, that need safe, decent, affordable housing. And for those of you who haven't been through some of the neighborhoods, you really need to drive through and see what life is like beyond where you live. So my question to each of you is, what more can the city and state do to provide the resources to revitalize our neighborhoods so everybody has a safe, decent home to go home to every night? Thank you.
Well, I'm always the rose-colored glasses person, so I have to point out some of the pretty incredible things that are going on in our community in a variety of neighborhoods. So when I think of the Wineland Park area and all the resources that have been put in there, J.P. Morgan Chase, OSU, the Columbus Foundation, United Way, a number of others, I mean, pretty significant changes in that community. The near west side, some work that's going on there, the south side, Nationwide Children's Hospital. I mean, there's some really incredible things that are happening to learn from and build on, and more resources to come in. Right, Amy, I totally agree, but it's been pretty heartening to see some of that as well. And the services that come together there too. So people are not just looking at, let's just fix up a house, but really help those neighborhoods to thrive.
So I would jump in there as well and actually build upon what Greg just shared, kind of those different ways of thinking about involvement, both corporate and really community involvement to achieve community health. And if we were really able to move from compliance, which I think many have, to from that regulatory to move further to strategic and then systemic thinking, we would have to be thinking about housing. And so again, what is it that is a barrier or the opportunity for us in working together? So one that was really teed up around this population health planning work that, Greg said we need to do it, and Amy's team stepped up and people from across the state came together, was that we really have to come up with a platform for health systems and public health to work together. And as some of you know, we have had here in this community, it's not true throughout the state, some areas, but not all. We actually do have a health assessment. We have had, and we have worked with our health systems and public health and some partners. Health Map 2013 was released in January of 2013, I believe. Health Map 2016, they're looking for a release date yet. It will be in 2016. June 8th, come here. The new health map, which is actually really what, technically it's not a health assessment, it's a health needs assessment, which is what the hospitals and health systems are required to do for their IRS obligations under the Affordable Care Act. It actually, by itself, is not sufficient from the public health standpoint, and we think to address some of these systemic issues. So we have an agreement, which we did the last time, and we will do it again, which we will take the health system and the partner, CHINA, the health needs assessment, we will be adding to it the information that speaks to disparity, that speaks to the other social determinants of health, that adds the life expectancy, education issues, incarceration issues, walkability, food access, et cetera, neighborhood by neighborhood. Because again, we think that will enable all of us to work together. So that will be hopefully able to be released by the end of the summer. And so as soon as the fall, I would like to offer any of you an invitation to join us, because we will be engaging in what's called a community health improvement plan. We've had those plans. It's time now for us to generate them again. Our health systems have some requirements around some of their strategic plans, but we in public health also have an obligation to create and support a community health improvement plan. So while there are some priorities, there will be lots of opportunity to look at priorities. We will link it to a state health improvement plan and a state health assessment. So again, I would invite all of you, come on June the 8th, but stay tuned, and if you have an interest, please let me or any of our colleagues know. We would welcome our corporate involvement, and actually we have done a lot of learning about what are some of the barriers, and if you want, we can talk about it, but really the opportunities. And ultimately, it is an opportunity for business, because if a community is healthy, it's good for your bottom line. And the bottom line for our community is also, if your businesses are healthy, we are a healthier community.
Great. Next question.
Hi, good afternoon. Thank you for being here. I'm Paul Carringer. We hear a lot about money, and we hear a lot about systems, and we hear a lot about different groups doing different things. In your view, what is it truly that we see as far as collaboration today across systems and driving the dollars into the system to make it more efficient and more effective? And what does it really need to be to get Ohio to where it should be, a leader and not a follower? What is that that's in the way of collaboration across the systems to make it efficient and effective?
Great. I think maybe we'll start with Greg. And I'm wondering if maybe you could share the New York State example too that we used as a part of the population health planning work.
Yeah, and what Amy's talking about is last fall, building on what Teresa was just talking about, what Teresa was describing is actually an effort in this community for folks to work together, develop an assessment together, and do improvement plans together. It's real leadership to be able to come together as a community and do that. Many places in the state don't do that. So every hospital has a separate assessment and plan. Every local health district has an assessment and plan. 123 health districts, 170 hospitals. We have 300 some assessments and plans.
Wait, and if I can interrupt, then there's United Ways that do plans, and there's alcohol, drug, and mental health boards that do plans, and it goes on and on. Lots of plans, lots of assessments, lots of implementation strategies.
So we went through an intensive process with HPIO facilitating at the end of the year last year to look at a few simple things we can do to help make that more straightforward. For example, instead of everybody being on a different schedule, let's just move to the same 3-year assessment and planning schedule. So now in each county, everybody is going to be doing an assessment at exactly the same time. Why would you pay for 14 separate community health assessments when you could combine your resources, do a community health assessment, and then base your plans on that? So we're going to have a bill later in the spring that formalizes that, but we think it'll be welcomed both by hospitals and by public health districts, just for the clarity it provides. So there are things like that where you can take your resources and just be more rational about how you use them to plan. The other thing I would say in terms of the organization, I think Ohio has moved to the front of the list of states that are seen as being effective in getting results with what they do with their money. For example, 4 years ago, Medicaid was growing in excess of 10% a year. We took that down to 4% in the first year and then 2% in the second year. From that more stable position then, the governor was able to make a decision to extend coverage to more Ohioans who happened to be the group with untreated mental illness, things that then lead to housing problems and other sorts of issues, because if you don't have stable access to health care, it causes other problems. Just like in reverse, if you don't have access to housing, it causes health care problems. So that idea of creating a capacity at the state level to be able to not break the budget, we're scheduled to go back to after we expanded the program, Medicaid program growth is below 2%. That is manageable within a state budget. So fiscal responsibility gives you an opportunity then to think about how to extend benefits and coverage to more people.
So I would, oops, can I speak? So that was a great question. So there's a lot of resource, and obviously Director Moody, Greg, is trying to help us all think about how could we use our resources better. So again, health systems, just in case you don't know, get about 85, 90, or 95% of resources come through the medical care side. Maybe that's what you were wondering about. And 5% or less, sometimes we think it's about a penny on the dollar, is connected to both prevention and public health. Public health is very underfunded. But that being said, it really is ultimately about working together. So you asked about how could we work together. Sure, we would like a lot of cash. That would help. But just this morning, again, infant mortality is a great example. Again, our Ohio Better Birth Outcome group is led by, well, through Children's Hospital, but it's all of the health systems working together on clinical care issues. Just this morning, I hosted, along with Dr. Roberts, our Chief Medical Officer who's here today, a group of all of the CMOs of the health systems, their lead OBs, their lead infectious disease, and their lead communicators, all coming together. We have just formed the Columbus-Franklin County collaborative to respond to Zika. So again, we do this all the time. It came up recently. Our community is better served, honestly, from a public health standpoint, but really this was our chief medical officer who said we all want to be on the same page. So again, there is a will to not compete in cases that really, I believe, will improve the public's health.
All right, one last question.
Hi, I'm Kelly Fryer with the Ohio Public Health Partnership. Jumping off on the theme of collaboration, we hear a lot about perhaps a changing role or future of public health departments with Medicaid expansion in the state. And I would like the panel to address a little bit your vision for the 121 local health departments in the state and perhaps how they may fit into the episodic based care or the patient-centered medical home care, and how we can be at the table to help plan and deliver.
I am very, very happy for that question because there is a fundamental transformation occurring with a number of community-based organizations that have always had a mission that has been critical to the community, but it's been a mission connected to the fact that folks did not have access to coverage. Federally qualified health centers are in part specially federally funded to cover indigent populations. Public health clinics often were formed to meet a demand for access to services that folks without access to coverage couldn't get access to care. If now more people have coverage and there's a source of payment for services, what does that mean if your mission was to serve a group who didn't have coverage? This is kind of shaking the foundations of some really important organizations in our community. For example, community mental health boards used to use levy dollars to then buy Medicaid clinical medical services to provide health care. That is all now at the state level, and those local levy dollars are not connected to medical care. What is the purpose of the board? Well, forward-thinking boards are realizing they can use that money to invest in housing and employment supports and other things that support people with mental illness and addiction So now Medicaid can be the source of coverage. You then augment what Medicaid won't pay for to provide those other services. So what's happening is some groups feel really threatened by this. Well, wait a second, I'm a Ryan White program, and I see my money for HIV/AIDS services declining. Well, it's not because there's less demand or less money. It's because folks are now getting those services through Medicaid, and it's paid for on that side. The question should be, if we have extra money here, what are we doing to now fill gaps and make sure we really address these remaining issues? So if you go right down through the list, public health nurses feel threatened. Public health nurses should be critical to whatever the care coordination of the future looks like. We have a number of what I consider kind of one-off programs, breast and cervical cancer program. We had 1,000 women enrolled in that program. When we expanded Medicaid, we brought in 4,000 women who previously were receiving no services at all for their cancer. So whatever it was we were doing wasn't quite sufficient. If we can get that into coverage and now repurpose those resources to meet the remaining gaps, I think that's a real opportunity. So you all are going to have you're on the boards. Some of you are on the boards of these organizations that are in a bit of a panic right now. And you need to turn that into something positive. Okay, if this is no longer our mission, if our mission is to help people live well in the community, well, then what are the services we can bring online to do that? And I think if folks don't figure out that fast, things like mental health levies will start to fail if people think, well, Medicaid took care of that, right? So it's something I think we're all going to have to think about.
So I would just add one counterpoint to that. We turn about 5 to 10 people a day away for sexually transmitted diseases, just as one example. So we haven't solved it all yet. Similarly, we have many people who do not yet have coverage, and many will not likely get coverage. So again, we are all thinking about this transformation. It is a real opportunity. There is more resource in the system, which is what Director Moody's pointing out, but there are still many who may not have that, and some of us are not going out of business yet. Which is why we need to coordinate. He's right.
Well, thank you so much. I hope you enjoyed today's forum. I sure did. You can view and share today's forum and all of our forums on CTV Columbus Television, on WOSU, and PBS affiliates statewide through the Ohio channel, and anytime on CMC's website via YouTube. Let's again thank our sponsor, Ohio Health, and our great speakers, Amy Rohling McGee, Greg Moody, Diane Radigan, and Dr. Long. And thanks to all of you for being here, and we hope to see you again very soon.